We wish to acknowledge this land on which the long COVID web operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So just as a reminder, the purpose of these sessions is to serve as a mechanism for sharing evidence-based information relevant for our various audiences and partners, and that includes decision makers, researchers, clinicians, patients, and caregivers, and the general public. Secondly, to provide ongoing updates and spotlights on emerging evidence, as well as about scientific activities and research results from our national network of researchers. And finally, to contribute to reducing and managing misinformation about long COVID. So in terms of any managing expectations for any exchange we have today with our guest speakers, I'd just like to say that while we value highly engagement around the science and its interpretation, as well as its application, commitment to reasoned discourse, as stated in our Code of Conduct for Long COVID Web, comes with a responsibility for all to ensure that any comments or questions remain within the spirit of positive, constructive, and respectful discussion. So we welcome any and all questions and comments in this spirit. Thank you. And today I'm delighted to welcome colleagues and guest speakers from different bits of Canada. We have Doug Ross, Gagan Nagra, Quentin Durand-Moreau, and they are all from the University of Alberta. And Behdin Nowrouzi-Kia, who is in occupational medicine at UHN and at the University of Toronto. And we're going to start with the team from the University of Alberta, who are going to talk to us about the complexities of workability and return to work in long COVID, evidence and experiences. And then we'll turn to Behdin, who will talk to us about the fatigue to function, occupational therapy's role in supporting individuals in long COVID return to work. So thanks. Over to you, Doug, and thanks very much, everyone, for being here today.
Well, thank you. Thanks for the introduction. It's an honor to be here today. We are speaking to you from Treaty 6 territory. Thanks, Susan, for the territorial acknowledgement. I'd like to share the University of Alberta's acknowledgement. Its buildings, labs, and research stations are primarily located on the traditional territory of Cree, Blackfoot, Métis, Lakota Sioux, Iroquois, Dene, and Ojibwe Saulteaux Anishinaabe nations, lands that are now known as part of Treaty 6, 7, and 8, and homeland of the Métis. It's also an honor to be speaking with two of my colleagues who are actually international award winners in the area of work and long COVID. Wanted to put this up just because I just learned about it on the weekend. Quentin was honored with the 2024 Annual Executive Committee Outstanding Achievement Award from the American College of Occupational and Environmental Medicine for a guidance statement on long COVID, which I believe he'll be talking a little bit about later. And Gagan, PhD student with me, won Best Student Research Presentation last fall at a Work Disability Prevention and Integration Conference. So it's an honor to be speaking with them. Wanted to start with my own conflict of interest statement. I have no personal conflicts of interest. I receive research grants and speaker honoraria for traveling every now and again, but I'm a full-time employee at the University of Alberta and editor of the Journal of Occupational Rehabilitation. Beyond that, no personal conflicts of interest. So we're here today to talk about work. Work is this, it's one of those four-letter words that we kind of have conflicting attitudes, opinions about both sides of the fence, some positives, some negatives. There's a couple of quotes that kind of personify that. Life is too short to work so hard, from Vivian Leigh. And there's no substitute for hard work, from Thomas Edison. So it is something that we have been conflicted over in our society. One big question, and again, this is partially where this conflict comes from. It's whether work is good for the health. Is work good for your health and well-being is a question that was tackled by Gordon Waddell and Kim Burton over a decade ago in a systematic review. They searched the world evidence, trying to answer this question. Are we healthier because we work, or are there too many problematic issues associated with our unsafe and unhealthy workplaces? So literature says that there's many, many benefits of work. And I'm talking work broadly, paid or unpaid, voluntary, work from home. Work is central to identity and social roles. Work helps meet psychosocial needs, and very importantly, work provides income. And we know that employment and socioeconomic status are primary drivers of gradients in health. And so there's many positive aspects of work on our health. At the same time, we know that work can be unsafe. And we know from the pandemic, our experience with the COVID pandemic, that many of the early outbreaks and locations of viral spread were at workplaces. These resulted in some locations in workers' compensation claims, insurance claims, including here in Alberta. And we saw very rapidly that not everybody recovered rapidly and went back to work immediately. There was early evidence of long COVID. In this case, I'm showing you data from the New York State Insurance Fund, an American workers' compensation claim or board that basically found 18% of people with COVID claims were unable to return to work for 1 year. As soon as we move into this realm of workers' compensation insurance, we run into a little bit of a problem with these prevailing conceptualizations of injury and illness. Traditionally, and also within our workers' compensation insurance policies and legislation, we've kind of worked under this injury or illness model. We think that after an injury or illness occurs, there's just a period of convalescence and recovery, and very rapidly people recover and return to work. We know that that's not always the case, especially in COVID. We know that long COVID is episodic and fluctuating. It doesn't follow this nice linear recovery process. It's unpredictable. There's not always a visible disability to be seen, many multiple interacting influences, and otherwise many things that don't fit the nice injury model. Long COVID is not alone, and there's several other conditions that do not fit that traditional model. One that I've spent a lot of time researching and working with over the past couple of decades has been low back pain. In fact, we know that low back pain doesn't follow the injury model. It's episodic and fluctuating. The recovery process is unpredictable. Many similar things that we see in long COVID. This is a qualitative study that was what we did kind of in the late 2000s, trying to understand low back pain recurrence, what it is, and what do people with low back pain understand recurrence to be. What we learned was that they didn't understand what we were talking about, that low back pain is kind of always there for them. It's a recurrence. There's a quote from one of the participants in our study. It's a constant. It's always there. It's a reoccurrence. It comes and goes and comes and goes, but it's always there. Even the anxiety of it is always there. This is that cover art. With this paper, we were able to select the cover art, and we picked this painting from an artist, Mark Halpin, who very effectively kind of showed this relationship between an individual and their pain, an individual and their condition. They're always there in the case of the shadow. So it's an issue. It's a broad issue with the injury model, and we deal with it. There are some other conceptualizations of work disability. This is one that I use in my research. It's very widely accepted around the world, although it hasn't filtered into some of the laws and policy around workers' compensation. This is the arena of work disability prevention. You see it's bigger, it's more complicated. I'm not going to go through all of it. We can see that there's multiple interacting systems. It includes not only the individual and their health condition in their workplace, but broader societal culture and socio-political influences on disability. One thing that's really important, and I think important for long COVID, is this model is diagnostically agnostic, meaning we don't talk very much around the injury or the illness. We talk about work disability, and we talk about solutions focused around that disability. So what are some of the solutions? I bring your attention to this article that was published just, I believe, last week. Work and vocational rehab for people living with long COVID in the BMJ. It was a practice pointer, great article, lots of great resources, some take-home messages, things that you need to know. But I will say that this was very focused on a UK, United Kingdom perspective. And we know in work disability that there's a lot of subtleties across jurisdictions, across nations, and sometimes things that apply in the UK don't apply here. Same thing with the US and Canada, Australia, you name it, around the world. There's subtleties that mean that we need to dig a little bit deeper into our own location. For this reason, my research team is leading a scoping review of interventions and recommendations for enhancing workability and facilitating return to work in people with long COVID. Our goal is to synthesize all of the evidence, broadly global evidence, but also some of the local evidence here in Alberta and across Canada, looking at return to work interventions for people living with long COVID. Our goal is to identify promising approaches for enhancing workability and return to work. This has been funded by the Glenrose Hospital Foundation. We're in the middle of this, and we're going to share some of the findings to date. Nothing's been published, so these are kind of hot off the press. Here's some of the recommendations for return to work. These are broad recommendations. 3 key factors: individualized support, workplace accommodations, and the critical role of managers. So we know that long COVID presents very differently in individuals, and these individuals then interact with unique workplaces, hence the need for individualized support. Tailored assistance, considering the unique needs and circumstances of the individual, is really crucial, and that came across loud and clear in the literature. Secondly, workplace accommodations, so important. And what's been highlighted multiple times in the literature is this accommodation needs to be gradual and extended or prolonged. You read quite often around prolonged return to work process, often required due to the unpredictable long COVID symptoms. I would highlight the Job Accommodation Network for long COVID. It has a fantastic website with a lot of recommendations around workplace accommodations. One last thing that comes through quite clearly in the literature is this critical role of managers. These are workplace managers. Supportive managers are who actively listen and facilitate accommodations, play a huge role in recovery. We're going to shift now into some of the promising healthcare interventions, and I'm going to turn it over to Gagan to speak to this.
Thank you, Doug, for highlighting long COVID in the work world. I think that was beautifully put. It does align a lot with invisible illnesses and chronic low back pain. I am working in the WCB Alberta Return to Work program for long COVID. And these are some of the promising healthcare interventions that come across in clinical practice as well as in research. So timely access to safe and supportive rehabilitation is necessary. What does that mean? We need to be able to provide multimodal rehabilitation, not just in person due to some of those symptoms, multidisciplinary or interdisciplinary teams. So we need those individualized treatment plans because long COVID is a heterogeneous condition, meaning individuals present with different symptoms. Each individual may need a different team member. So in our program here, we have OTs, physios, psychologists, and kinesiologists, but depending on the long COVID program that you are initiated into, you could have different team members on the team. Some program components, psychoeducational approach is necessary. It even shows in research, patients have highlighted the importance of education around pacing, breathing strategies, tailored physical activity, and medication management. It's also important to recognize that having early education is something that's being highlighted around pacing. So in our program here as the OT, I address cognition, brain fog, sleep hygiene, sometimes nutrition, but mainly that pacing approach and how to manage your energy. And then intervention duration can be anywhere from 3 days to 5 weeks, but also in the clinical world with WCB, we have a 6-week program, but we can extend it to 10 weeks. And we've seen here with experience that sometimes individuals do have a setback. As Doug mentioned, it can be alongside that fluctuating episodic disability framework. And what that means is sometimes individuals start the program, they make some gains, and then have a bit of a setback as we're still navigating that area of long COVID. Next, some contraindications that come up in research and the clinical world is performance-based functional capacity evaluations for those who experience post-exertional symptom exacerbation. Essentially here in the program, as I mentioned, we have physios and kins. Graded exercise has now been considered a contraindication for those who experience this post-exertional symptom exacerbation. What this means is some individuals do some activity and then either immediately or have a delayed setback due to that exacerbation. We can do the FCEs over multiple occasions. As I mentioned on the previous slide, multimodal, we can even do it, parts of it maybe virtually or hybrid, and that helps with that evaluation. And as I just mentioned, we do not do exercise-based graded activity for those with post-exertional malaise. This is also important in the clinical world for return to work. Typical gradual return to work looks graded as well. We might start at 2 hours at 2 days a week, move to 3 hours at 3 days a week. We are noticing that the gradual return to work plans for long COVID individuals are anywhere from 10 to 20 weeks versus our typical programs. We try to keep those anywhere from 4 to 8 weeks. This is again allowing that pacing and energy conservation to be a part of the return to work. Some ongoing challenges is, again, the confusion around long COVID. There are some areas that still need, multiple areas that still need research, especially the diagnosis and definition of long COVID. And there's inconsistencies around the world, as Doug mentioned, UK, Canada, US, Australia, and even within our insurance systems here. WCB Alberta has a specific way of accepting a claim versus Manulife. Just had an individual this morning, had to switch over from Manulife to WCB. So we're still navigating those areas. And then lack of testing. You know, early in the pandemic, a lot of individuals were told to just stay home and isolate unless there was a specific reason, such as a frontline worker who needed to go to work, that were invited into testing. And at that time, long COVID wasn't even considered. So when individuals ended up with long COVID or symptoms lasting for long periods of time, many of them don't have that positive test, which is necessary for claims benefits. And that brings us to this here. Ottawa will stop providing COVID-19 rapid test to regions. You know, this has mixed messages for individuals. We've talked about it here in clinic, actually. For the WCB Alberta world, for example, our claims have dropped drastically because we're not isolating anymore, so it's hard to trace it back to the workplace. But again, to be eligible for that or Manulife, they often are looking for positive tests. And if you don't have a positive test, you're jumping through multiple hoops to prove that you had this history of COVID that got to this point. So that can make it quite difficult for claims benefits, but also there are individuals who are saying, you know, there's false positives, so do we even need the testing? So I think there's going to be interesting talk around this. And I'll pass it over to Quentin.
Thank you very much for passing it over to me. Here are my disclosures. I work as an occupational medicine specialist and assistant professor at the U of A. My grants are mostly public related, and I also have an editorial role for a journal in the field called Occupational and Environmental Medicine. So on the next slide, I'm going to just provide you with an overview of what occupational medicine actually is, and what's most important is that it's not occupational therapy. I have nothing against my colleagues in occupational therapy, but a lot of people are confused between our role and the role of occupational therapists. And sometimes healthcare workers and sometimes physicians themselves are a little confused. So occupational medicine is actually a subspecialty in medicine where we deal with work-related health issues. And it's mostly two sides of the activity that we have. The first one is to help workers to find whether their condition they're present with is work-related. So we conduct assessments, we take occupational histories. Well, we discuss for a long time about the career of a worker to look at exposures and try to make connections with the condition that they present with. So with regards to long COVID, we're looking at whether there have been exposures at the workplace and whether there is some temporality that matches the work-relatedness, meaning you need to develop the condition after being exposed. And then we help people go with WCB. We are separate from them in our clinic. And then the second side is all of what pertains to fitness for work. So it's about accommodations, limitations, restrictions. And the idea is to find really the framework that's going to help the worker go back at the workplace. Sometimes we advise that it's not the right time for them to go, and we defer this. Sometimes after quite of a long follow-up with the patient, we find out that it's not relevant that they ever go back at work. So we help them go on permanent disability. Occupational medicine is not a very well-known specialty. Actually, we're very, very few in the country to have specific qualifications in the field. But there are a couple of occupational and environmental medicine clinics accessible for outpatients. And in Alberta, you will have the K Edmonton Clinic in Edmonton, where patients can come and see us with a referral from their healthcare provider. So on the next slide, I do have two complex stories to just give you an illustration of the situations we try to deal with. And when I say try, it's really like it's complicated, and I don't pretend to have, the key to understand everything and to provide the perfect solution. But here is what we can see in our clinic. So the first situation is a chief nurse in his 40s. He got COVID in 2020, so really early in the pandemic. He ended up in the ICU. He was discharged home on oxygen. And as he got COVID at work, he was covered by WCB. But I'm following up like for the past 3 years, and still as of 2024, when I last met with him, he had pulmonary problems visible at the CT chest. He was very fatigued, and he still has some brain fog, like many of our long COVID patients. And one of the problem is that as he was a chief nurse, actually working in the ICU, just the idea of going back to the very workplace where you almost got killed is very complicated. On top of all of the difficulties to just go to any workplace, the psychological relationship with this very workplace makes it very difficult. So we are trying to find, how the transferable skills can be used so this person can move to another area, but it's very complicated, and we make quite a limited progress. But that's one point with a lot of patients, that return to work sometimes has to be discussed to the place where they got COVID from, and if people ended up at the ICU, it might be very traumatizing for them. A second case is another patient that I'm following up with for quite a bit. It's an automobile appraiser, so someone that assesses vehicles after accidents to see what needs to be repaired, what needs to be, covered. They're working with insurance, and they need to assess vehicles to find what mechanic pieces are to be changed, and whether the insurance is going to cover for them. This individual got COVID in 2021, and he got one of those symptoms that we've been talking quite a lot in patients with COVID, anosmia, meaning like the smelling problems. And when you work as an automobile appraiser, it's complicated to deal with such issues, because you use all of your senses, including the smelling, to find leaks and to find out some problems. On top of this, he has some issues to work on the screen. So when he had all of the input phase of ordering the parts that he needs to order on the screen, it's very complicated for him. And also brain fog, as many of our patients with long COVID. So he tried to go back to work, and as we outlined, with a very, very progressive plan, 1 hour, no pressure, and it didn't work. Like, it was very difficult. So we try to find support for the smelling issues, like, that there might be kits with little different bottles of different odors for people to get trained and to retrain their smelling, but using this, they don't work. So we're awaiting expert advice with this. The thing is that in our clinic, we see the very complex situation. Remember that not everyone knows about occupational medicine. So we end up having patients referred by expert centers, and within these patients is those that are struggling most at the workplace. So the recruitment we have at the clinic is very biased. We see patients that are in very complicated situations. So I can't speak to, whether or not it's a general trend to have so many difficulties. It's unlikely that everyone struggled that much. Some patients have not been able to go back to work at all or for many years after they got COVID, and finding suitable accommodation is quite complex. Sometimes work from home arrangements are possible. Reduced hours, modified duties can be considered. I was with a patient with long COVID last week. She's been out of the workforce for 3 years, but successful in going back, which is already some sort of significant progress. But she maxed out after reaching 3 half days a week of work and with finding specific tasks that she can fulfill. So people might go to the workplace, but are not able to go back to previous duties sometimes. And my final slide is just to show you this paper that Doug mentioned earlier, the long COVID ACOM guidance statement. So with the American College of Occupational and Environmental Medicine, I'm part of this association, which is a bit larger than the Canadian occupational medicine specialists, because there's more occupational medicine specialists practicing in the US. It's been decided at the top level of ACOM to have a guidance statement for long COVID to help occupational medicine providers to help patients dealing with this condition. So it shows that there is some recognition that the problem is important, and there are some projects to provide specialists with resources to help them both on working on accommodations that are suitable for them, and also to provide them with a structure and arguments to help patients get compensated with workers' compensation. So I'm going to hand over to the next speaker, and this is the end of my presentation. Thank you very much.
Thanks, Quentin. Yeah, so this is the end of the 3 of us. I would say that we're happy to answer questions here. I've got my email here if anyone wants to follow up with me after the presentation. I would acknowledge our research team, and this includes Behdin, who we're hearing from next. So it's a nice segue. I will
That's
stop
terrific.
there.
Thanks. We'll just pause for a few questions here. I'll pull some from the chat here. First, we have Lorraine, who talks about a recent recommendation that was for patients to each have a healthcare guide assigned to them. And what is your knowledge of where and how this is being done, and the benefits to having a health navigator for patients?
That's a good question. I know that has come up a few times in different articles that I've read, definitely recommendation out of qualitative research. I think a limitation is people with these kinds of roles aren't necessarily built into the systems. I know within workers' compensation and insurance, private insurers, they will have a case manager. But sometimes that role can be different, and they're perceived as representing the workers' compensation board or the insurance company. So I think this navigator is different. It's definitely something that we need to give more thought to, and how we can build that type of a position right into our health systems.
And just following on, there's another question from Lorraine, but has your work influenced the sort of, perceptions and behaviors of physicians in terms of acknowledging long COVID in your neck of the woods or elsewhere where your studies have had some influence?
Well, I could say in Alberta that I think we've had a small impact. I think that one thing that Alberta has done is implemented a care model, a rehabilitation model related to long COVID. And I would say that even the Workers' Compensation Board was very progressive in starting long COVID clinics in the early stages of the pandemic. This is where Gagan worked in Calgary in one of these clinics. So I like to think that we've had some input or impact on these physician perspectives. No guarantee, and I don't have a lot of concrete evidence to say that we have them.
Hard to say. Okay, that's great. Thanks. And is there anything else you'd like to mention about the measurement or consideration of post-exertional malaise in your work?
Well, it's definitely a problem. I'm wondering if Gagan would like to tackle this, Gagan or Quentin. I think that this is one of these really, like, a problematic symptom that has so many implications on making recommendations around return to work and activity. So Gagan or Quentin, I don't know if you would like to tackle that one.
Yeah, I'll just add there, I do want to highlight that I've answered quite a few questions there. So if for individuals that want to see some of those answers, you can just collapse it there and see that. But in terms of post-exertional malaise, yeah, as Doug said, it's a pretty gray area. We know that individuals coming in, it's very subjective at this point. We do some questionnaire screening. We do have some baseline tests that are considered a bit easier, such as a 1-minute sit to stand test. But again, if an individual says that, they're not comfortable doing that, or we have people that come in with oxygen, we choose different measures. And we try to give them an exercise plan that they self-monitor. I think that's key in the exercise component, is very much self-monitoring and deciding when to take a break and taking that break before they feel tired. So using pacing. Quentin, anything you want to add?
Yeah, so on the occupational medicine side, one of the key issues, the key problems we run into is how accommodations are being effective. And this really pertains to the duty to accommodate, which is, it's not under our control as healthcare providers, generally speaking, but there is a duty to accommodate. And I tell my patients, it's not an option to accommodate, it's a duty. And it's in Alberta covered under the Human Rights Commission. So the problem is how this is enforced and how people really respect this obligation. And all of this, needs to be tackled by stakeholders and governments to be a little bit more serious about this. So, we are not in a situation where patients just tell us, well, my employer doesn't want to provide any accommodation. We're not even allowed to sit in the workplace, which is unacceptable by definition. So that's really one of the huge issues I'm running into. And this makes the difference between patients where we can make a little progress with them and have them even part-time in workplaces, as opposed to those who are staying off the workplace at all with no possibility to get there for them. Like it's one of the major issues, and I think we need to do some advocacy with regards to this.
That's terrific. Thank you. I know there are questions unanswered in the chat, and I understand, Sue, that you've requested to be unmuted, but we've now run out of time, and the team have generously offered to answer questions if you email them. So I just suggest that people could follow up directly with the team. Thank you so much, Doug, Quentin, and Gagan. It's been a terrific overview, and really appreciate the time and your presentations. A lot of really important information there. Thank you. So let's turn to Behdin now, and your slides, Behdin, and take it away. Thank you very much.
Great. Thank you so much, Susan. And I wanted to thank the Long COVID Web for the opportunity to speak today, and also to thank Doug for including me as part of the discussion on work and long COVID. I think it's a really important topic, and one that I think my colleagues from U of A have done a fantastic job discussing. Hopefully what I'd like to convey in the time that I have with you is just an overview of how occupational therapy can play a role in it. You've heard from Gagan and Doug and Quentin around the role that healthcare providers have. I kind of maybe want to delve a little bit more into that, explain to you what the profession is and how we can potentially contribute as part of a broader team and multidisciplinary team approach. So forgive me, but I do also think it's important to recognize the traditional lands that I am at. I'm at the University of Toronto. I'm in the Department of Occupational Science and Occupational Therapy. So I like to acknowledge the land in which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this is a meeting place, is still home to many Indigenous people from across Turtle Island, and we are very grateful to have the opportunity to work on this land. So it's really important for me to do that, to express gratitude and appreciation to those whose territory we work on and live on, and as a way of honoring the Indigenous peoples who have been living and working on the land from time immemorial. So a little bit about me. Those are my disclosures. I'm a faculty member and assistant professor at the University of Toronto. These are the grants that I hold, which is a mixture of tri-agency grants and also private sector grants, as well as some honoraria to speak at different events, and some consulting fees through some of the engagements that I have through my own private practice, and also research consulting and some of the organizations that I work with, particularly in the skilled trades in Ontario. And I'm also, like I said, an employee of the University of Toronto, and I'm part of the Journal of Occupational Rehabilitation as an associate editor. That's just a little bit about me. I'm really happy and honored that I get to profile just a little bit about the work that my group does. So I have the privilege of being the principal investigator of the Rehabilitation Sciences through Occupational Research and Engagement Lab. And together we really look at ways to improve health and well-being using an occupational lens in workplace settings. So if you do want to learn a little bit about what we do, I'm really proud of our equity, diversity, and inclusion statement. You can look at that and see that this is part of our group. And, you know, being in a city like Toronto, it's a very diverse city, and we try to bring people that represent that diversity in many different ways, the lived experience, their work experience, where they may have been born and come to Canada as newcomers and settlers to the land. So we really do try to make sure that we represent the communities and individuals that we serve. And I like to put my contact information a little bit earlier on so it doesn't get rushed at the end. But if you're interested in working and learning more about the kinds of work that we do, I have that information there. And I'm also affiliated with the Center for Research in Occupational Safety and Health that's at Laurentian University in Sudbury, Ontario, Canada. So a little bit about what I'd like to convey in the time that I have with you is really just explain what occupational therapy is. You heard a little bit earlier from Quentin about the differentiation with occupational medicine, and talk a little bit about what OT can contribute to the area of long COVID and return to work. Look at some of the key considerations and recommendations. So we'll identify some of those, particularly when it comes to identifying perhaps the discourse or the goalposts where we can talk about where me as a healthcare provider can provide some input, and also as a researcher putting that hat on in kind of shaping what research can look like going forward in this area. And then really look at workplace accommodations. I heard that term from the previous speakers, and using a biopsychosocial approach and really highlighting where perhaps occupational therapy can provide input, which is, you know, we have the privilege of having the time and the opportunity to engage with people, listen to their narratives, understand what it is that their unique circumstances convey when it comes to living with long COVID, and then provide us with an opportunity to work together in hopefully addressing some of these complexities and mitigating potential adverse effects when it comes to going back to work. So what is occupational therapy? It's a healthcare profession. For those of you that may not be as familiar with it, we work with individuals to support their daily occupations. That's our jargon for saying activities. Oftentimes, we're looking at people, they may want to or need to do activities that are important to them, whether it's self-care activities, those that we take for granted, many of us anyway. When we get up in the morning, we brush our teeth, we take a shower, etc. OTs are very well versed to kind of assess and provide recommendations, treatment options, and that can look well beyond the workplace. And we're regulated healthcare professionals, meaning that we do use evidence-based approaches. So we do look at the evidence and make recommendations based on what we think is appropriate in the literature. So, and we work in a variety of settings. Oftentimes you might think that OTs work largely in healthcare settings. That is true, but we certainly work outside of those settings as well. So OTs have worked in education centers, the criminal justice system, governments, etc. So it's a very broad field. And today I'll be talking to you a little bit about how what that looks like in the health and safety aspects of it, and particularly when returning to work and long COVID. So some of the activities and approaches that OTs provide, you heard some of them from Gagan a little bit earlier about, for example, integration, education, case coordination, and so forth. So all of these are part of our toolkit, and we use that through a biopsychosocial approach to address some of the complexities that we encounter. We also oftentimes, this is a model that comes from occupational therapy. It's about 30 years old now. I came from McMaster University in Hamilton, Ontario, and it looks at essentially, as OTs, we oftentimes look at the person, we look at the activities they're doing, or what we call occupation, and then we also look at the environment, and we use those terms very broadly. So it's not just the built environment or the physical environment, but it includes what you heard from Doug earlier about the psychosocial construct, the social environment, all the complexities that we live and breathe every day as we go through our life. And we look at the confluence of the three, and where that confluence occurs to us as OTs is an opportunity to intervene. And that confluence is really what we call occupational performance and participation. So really what it means is we try to look at the person, what it is that they're doing and where they're doing it, for as an example, and then try to maximize where we can provide opportunities to augment functioning. You heard a little bit earlier from Doug about Waddell and Burton and their work really emphasizing that work can be therapeutic. As occupational therapists, we're very much well versed in that if you're doing something, if you're engaging in activity that can have beneficial effects to you. Of course, there can be too much or too little. Sometimes we use the term occupational deprivation in our field to say, for example, if you haven't had enough activity, that could be constraining and could be poor for your health. Similarly, if you've had too much, you could also be experiencing deleterious health outcomes such as burnout and things like that that are very much pertinent today when we're talking about long COVID. Similarly, I won't dwell it too much, but like the other speakers, I also use something called the Work Disability Prevention Framework. I like it very much for many reasons. One of the ones that what really speaks to me as an occupational therapist is that it puts the individual or the worker or the employee, whoever you like to put here, at the center. So really they're interacting with these different systems, and the complexity is here for us to appreciate as we go through this talk and perhaps in the discussion, but only to highlight that this is very involved. It requires a lot of different participants, and not all of them are going to be healthcare providers. And I'll make some notes of that later. But we play a role, for example, coming from the healthcare side, but we're not the only actor. And I think people appreciate that, but it also speaks to the fact that this is complex. I also wanted to just highlight some of the work that's been done in this area. And this quote spoke to me. It's from the Wellesley Institute, which is a research institute here in Toronto, Ontario. And they did a study looking at the work experience of people with long COVID. And I'll just read this quote because I think it's, it talks about that episodic nature of it, the waxing, the waning, the fact that people have good days or bad days. And the fatigue has always been pretty intense. What was a lot more difficult for me to see and to accept was that I have some cognitive limitations. It was hard for me to get through the workday. And so I was kind of trying to hide it from my boss, like take breaks in the day when I wasn't too busy. But I noticed that it was really hard to concentrate and pay attention and learning new things. And then sometimes I'd notice that weakness. It was extreme. And, some of the work that we've done that hasn't published yet also looks at this in different types of conditions. For example, people that live with lupus and similar kinds of episodic nature of having good days versus bad days. And I thought that spoke to it as well. Similarly, as interprofessional healthcare workers, we do have a role to play, for example, when it comes to advising, communicating, working with other healthcare professionals and those outside the healthcare system, such as direct supervisors, managers, allies, such as associations or unions that may be involved, to provide our opportunity to support return to work and also help with that transitionary period that might involve someone who's been off work for a period of time, going back to work or staying at work, and really understanding what the nuances of that are. And it's complex. It can be individualized, and it should be. And I'll talk a little bit more about strategies around that and how we can use a biopsychosocial framework to achieve that. So, going back to work, for those of you that have either experienced this personally or have worked in the context, that oftentimes clients or our patients will say to us, am I ready? What if I fail? Can someone help me? Will I be treated differently? Maybe I need more time. And all of these are completely normal responses that we have, because naturally, what if you go back and you're not successful? What does that do to you personally, right? So what if God forbid, you're hurt again, or you're ill, or you have a disease that can be attributed to the workplace? Like, that could be a lot of setbacks that obviously nobody wants to experience. And as the health provider, you don't want to put someone in that position either. Just from a mathematical perspective, those that you like to see graphs, this type of data has been supported for many years. There's from different populations, from low back pain to so forth. And it really just, what the message that I'm trying to convey to you is that the longer somebody's off work, the less likely they are to go back to work. And this is a general trend where we notice that basically work avoidance isn't the solution when it comes to supporting return to work as a totality. And we know that the longer they're off work, so approximately 12 months down the road, you've got maybe a 32% chance of going back and being successful with your return to work. So what are these are some of the challenges we're facing. So what can we do about it? I think from a broader macro perspective, like a bird's eye view looking down for this, we can turn to some of the evidence-based technical standards that are available in the Occupational Health and Safety Suite. So they may be the CSA, Psychological Health and Safety in the Workplace, really looking at the mental health aspect of things. And we know that as people experience long COVID, it's not in isolation. It's no longer just one aspect of it, but it's a complexity of everything that involves around our physical health, mental health, and so forth. So that standard can provide some guidelines. It has domains on how to structure the mental health piece. And I think if you look at another standard that can really help set the discourse of that framework or the goalpost around all of this discussion is looking at the Work Disability Management Standard that came out a few years ago. And as those of you that are healthcare professionals, but also employees, workers, and others can appreciate this, because this standard really looks at providing an opportunity for everybody to work together. It can work across different sizes of organizations. It also provides us an opportunity to kind of delve deeper into the complexities of return to work and work accommodations. So for those of you that are healthcare providers, it has what's called an informative annex, so an Annex B in it specifically. And what it does is it shows you kind of what we as healthcare providers can do. We're part of the team when it comes to, for example, as Quentin said, identifying limitations and restrictions and providing recommendations around that to the employer. But we're certainly not the only part. We recognize that here in Ontario, just like in Alberta, the Ontario Human Rights Commission has the duty to accommodate clause, and that employers have to make an attempt to support somebody's return to work. But of course, that is part of a much more broader discussion that we can have. But these types of standards can really help kind of set those parameters into what should we include in our discussion, who should be there, how do we look at these types of considerations when it comes to supporting people going back to work. And then similarly, from the Institute for Work and Health here in Toronto, again, they've identified for many, many years now the principles. They call them the 7 principles for successful return to work. And if you just put this in your web browser, and I'm happy to share this material with you afterwards, they talk about kind of the pieces that you need for supporting successful return to work. And many of them may seem rather straightforward and commonplace, but there's evidence to support them through systematic reviews and other literature that's been carefully looked at. For example, supporting a positive workplace, the employer providing modified accommodations, return to work plan being very deliberate and having someone assigned to it, and the supervisors being involved in that. I saw a question in the chat around what are supervisors learning, what are insurance providers, funders doing. So there's a role for all of us. And if you again imagine that arena model that Doug was talking about earlier, that's kind of where we can see a lot of the other stakeholders and actors being involved in this return to work journey, and also providing communication. I can't think of how many times from a clinical perspective I've talked to a client or a patient and had them not tell me, nobody from work called me, nobody recognized the challenges that I'm facing, and I feel like I'm doing this all alone. So like communication is a huge part of all of this. And I also want to recognize that some of this work has already been done by my colleague in the Department of Physical Therapy, Kelly O'Brien, and others, and they provided recommendations for all of these different actors to get together. There's no way I can get through all of that material, but I invite you to kind of look at this because it specifically looks at return to work and those individuals that are living with long COVID, because it provides us at least with some sort of understanding, because we're in the early days of this from an evidence-based perspective. There's a lot that we don't know, but what we do know based on documents like this and what we've learned from other populations can really serve us well in kind of taking this step together and moving forward. So, just some takeaways. Just recall that, as OTs, we're evidence-based practitioners that use a PEO framework, so the person, environment, occupation, to really align where we can provide interventions and opportunities to maximize functioning. And for example, with people with long COVID, that could be across the board. It could be opportunities in the workplace. It could be that home work interface and so forth. And we may be able to identify work instability. What I mean by that, or work incongruity, is that if there's decreases in function, and people will experience experience that, that's exactly where we can provide assessments through different tools, different outcomes that you listened to earlier, FCEs, job demands analysis, etc., that can give us an opportunity to fix that misalignment or that incongruity between the person's ability to do the job and what is expected of them. And then similarly, we can use a very biopsychosocial and holistic approach moving forward. So from my perspective, OT has that opportunity to kind of not just, and I'm not criticizing the biomedical model, it has a very important place and I'm a believer of it, but in these types of circumstances, we have to go beyond that and look at it through a biopsychosocial model as well. And then finally, I just wanted to tell you a little bit, if you're interested in kind of looking at the OT role in this area, in long COVID, in return to work, and much broader than that as well. Last year, the Ontario Society of Occupational Therapists provided a Work Disrupted podcast series. It's available wherever you get your favorite podcasts. And in it, there's interviews with different occupational therapists across Ontario, and they talk about their role in supporting workplace outcomes. A lot of it is on mental health, but in it, you'll get to learn more about the OT role, particularly when it comes to supporting return to work, and I think also with long COVID as well. I think that's it for me. I'm just going to stop there.
That's
And,
terrific.
yeah.
Thank you very much, Behdin. Really thorough and thoughtful overview. And I love that you emphasize the teamness of the effort that's required and the sort of multifaceted context in which people need to think about in terms of what's needed to return to work. So that's really helpful. So some questions in the chat. I'll just start with the first one there after you started. So I know that the focus of this entire session has been on long COVID and work. There's a question about, it feels like youth and young people in terms of returning to normal activities and getting back to school has largely been missing from the discourse. I just wonder if any of you can chat about any work in parallel that's been focused on getting young people back to school or back to normal activities. Could be for anyone on the panel today.
Nothing that I'm aware of, unfortunately. No, that's definitely a huge area of need.
So another webinar focus, perhaps. That's great. Good. And we have, thank you, Sue, for offering to share your Twitter feed there. That's great. And Sue Birch is also looking for a research partner with her Gmail there. So if anyone is interested in talking to Sue about what could be next in terms of the work there. Aaron talks about how it's difficult to hear that. I think you're talking about the decline in probability of returning to work over time. Is there anything that anyone might offer to Aaron in terms of thinking about things to put in place? Or I know you positioned your 7 principles bit in. Is there anything more you'd like to offer there?
Yeah, I think so. I mean, as I mentioned earlier, and I think you heard from my colleague, this is really a multidisciplinary approach. So there are many of us, an interdisciplinary approach, those of us on perhaps more aligned on the health side, but then outside of that as well, and having your advocates in each of those corners would be very helpful. So someone on the healthcare side can speak to the accommodations piece, the aspects of what the person can do, what they may have more challenges for, and then kind of provide those types of contextual recommendations. But it goes well beyond that. Like, I mean, if you're working in an environment where there are unions involved, or you have an association or other types of allyship, they may also come to the table and support you, because I think oftentimes the communication piece is huge, and that communication piece can convey material or information that the other side may not be privy to, or that has fallen through the gaps. We know that the system is complex and it's large, and unfortunately in some places and in some instances it's fragmented as well. So just having that opportunity to have advocates and those to support you at the table will help as well, and to go beyond just the healthcare model. As a healthcare provider, I'm saying that to you because I think in circumstances like this, when it comes to return to work, we have to look at the much bigger picture, and that ARENA framework could be a great way to at least frame some of the discussions around who those potential other actors could be.
That's great. And then a comment that perhaps the data on that chart is not actually from the long COVID population. Is
No.
there, so is there any thinking around how it does apply or may not apply under some conditions?
Yeah, thanks for that comment. And you're absolutely right. I mean, a lot of what we know already is based on other populations and not the long COVID population, just because we're still, like I said, in the early days. I would imagine that, it's going to be complex and involved and may take even longer. So that it may not be the same relationships, but I only wanted to bring that chart up to show that, work avoidance isn't the solution to any of this. So meaning like if I stay work on longer periods of time, but finding a way that you can be engaged in the process is going to be beneficial. That's what all the evidence that we have presented today and many others that we haven't had an opportunity to present shows as well.
And I think there is another comment from Anne Bear. Maybe we could unmute Anne on this topic. Anne, are you able to go ahead?
Unmute. It works. Okay. Sorry, I cannot write it because it's not clear enough in my mind. I've been wondering, and it will take me ages to go into the literature on, time elapse and probability to go back to work. But I'm just wondering if in all those studies that we have for a long time, they're often for different conditions where, for instance, there's no PEM. And I'm wondering if it's at any time sort of factored in the ability to do ADL and IADLs and the evolution of the person regarding if eventually they go back to work, meaning that I understand we talk about work avoidance. There's all the mental health issues, but I'm just wondering if the current statistics are not taking into account the complexity of the disease and putting it all together, not really have the proper clusters to evaluate the probability. Sorry, I'm not sure it's clear, but I'm just feeling that we might be missing something in those statistics. And they are, on the other end, discouraging for people with diseases such as long COVID or any other diseases. So I'm just trying to think here.
No, I think I'll speak, and others, I invite my other colleagues if they like to add to this. I agree with you. I think they're definitely misleading, and we don't know. I only presented that information to kind of give us a sense of at least what's available to us in the literature, but I agree with you. We don't know. And when it looks at functional outcomes, my group is very much interested in that and kind of moving away beyond just the symptomology aspects or just symptoms and looking at functional outcomes. And we simply don't know how it impacts ADLs on the long term and IADLs, like things like driving, finance, shopping, etc. So it's a poorly understood area in general, if I can add to that, Anne, but one that we'd like to explore further. I think from my perspective, function is critical to this, but it's not been one that's been extensively studied. But there's lots of opportunity for us to kind of work together and study that. But it's going to take time for those types of outcomes to also be generated.
Yes, and I was not implying that you should not present those data. I know they're all over the place, and that's the current knowledge we have. But I just I've been having this questioning for a while now, and I can't get my hands on understanding what I feel is missing. So that's why I asked.
Thanks.
So if I could comment a little bit on that, on the survival curves and the outcomes. So that is the return to work outcome. It's not looking at the functional or ADL or other outcomes. And it's showing worst case scenario without intervention, I would say, right? Like this is, if you leave someone on their own and they don't have a supportive workplace, it's just like, it's not great. What we've seen is that you can turn those around and the curves look very different with appropriate assessment and appropriate intervention with close communication with a supportive workplace. The one thing that I would say with long COVID is that the curve is actually it's long. So when we're talking about accommodations, it's prolonged and extensive. And many times it's like in and out of the workplace, in and out, in and out. And it kind of looks like recurrent. So that's why I put in that slide about low back pain. It comes and goes, but it's always there, right? And so it does look like something that might take years of suitable, appropriate, accommodated work.
Thank you. Oh, I think we'll just have one sort of general broad question that captures a few of the questions that have come up in the chat, which is about sort of the efforts from your teams around knowledge translation and influence around employers and insurers, perhaps. Can you just talk about the efforts that that you are making with your team to share this knowledge with those two groups, and perhaps what you're hoping to achieve there? Sure, small question.
Yeah, maybe I'll be very quick and allow others to provide their input as well. I think from our perspective, I think that's a very important point that you raised, trying to get others, particularly on the funder side, the compensation side, to understand the complexities of long COVID. We, sharing that, being in front of them, having an opportunity to do that is kind of the approach that we're taking. And we want to disseminate the knowledge in very broad settings, kind of like this webinar today, and places where they will be, rather than just talking to other people like myself that are in the research sphere and so forth.
Thanks, Behdin. Doug, or others?
Yeah, no, I agree with that. And, communication is a challenge. I see that Lorraine is here and she's a real expert in communication. What we found is we have to communicate in different ways for different actors, like what Behdin was talking about, right? So when it comes to insurance and workers' compensation, I would say I wish that I knew how to communicate more effectively with them. I do try to enter the meetings, the dialogue, the meetings that I've been invited to. I plead the cause of people with long COVID, but it's challenging. And I think there's so much inertia from that prevailing conceptualization of the injury or illness model that I talked about at the very beginning of my talk, that it's hard to break that. It's hard to break out of that. It's just in us. It's in us as a society. It's within our systems, but it doesn't work. I don't know, Quentin, you're dealing with that a little bit. I saw in your guideline statement.
Yeah, no, one of the challenges is when we have to provide medical information to insurers, and some of them are kind of misleading in the sense that they, like, I remember one insurer in particular saying like, what are the objective findings that you can find for this patient? And then the next question is something like, if there are no objective findings, please outline the return to work plan. And they are totally missing the question on tolerance when there's no objective findings, but all of the brain fog, all of the pain, like those wouldn't qualify from the insurer perspective as objective finding. So what does it mean? Like the insurer is kind of pushing physicians that are reading through this kind of questions for the physicians to say that when the patient doesn't have any visible objective finding, like 6-minute walk test that is altered, or PFT findings that are showing any restriction or whatever, when it's just about brain fog, when it's about pain, when it's about fatigue, okay, off we go, we're like full-time at work, and that's something we have to push back. So I'm trying to educate them in the sense that I tell them, well, in occupational medicine, we don't just take this into account, but we take the concept of tolerance, which is also the capacity from the worker to tolerate work. And not all of this is objective. But I think that they are also using this as a strategy to try to minimize payments. So we also need to use this as a pushback, but I'm not sure that a lot of family physicians are able and equipped to do this. In OCMED, it's our area of expertise, so we can, have arguments to tell them, no, you still have to compensate, because all of the subjective findings do exist for the patient. It's not because you can't measure this that it doesn't exist. So yeah, that's a very complicated point, and I think it should be something where we need to communicate more broadly to insurers and workers' comp sometimes to help them understand this.
Gagan, anything to add, or should we wrap it there?
I just wanted to say, just to add to that, Quentin, I think it, from a clinician perspective in clinic here, we've talked about having an in-service with some case managers, but really it does come to individual advocacy. So we have those return to work planning meetings, or we have case management meetings with claim owners, and it's really just educating them using research that's out there at this point and advocating for clients. And yeah, Quentin, we do find ourselves in a situation where typically we're trying to objectify or have some objective information for those other areas. So for brain fog, trying to do those standardized cognitive assessments or screening, but then fatigue kicks in and they can't perform the entire assessment. There's quite a few barriers and quite a few areas that still need some research in terms of long COVID.
Great. Well, I think we'll close it there. We're a bit over time, but thank you so much to our speakers today and for everyone who attended the very short webinar survey, just to gather any feedback about how that we could make this more useful for all of you. Please feel free to click on that and give us some of your thoughts. But have a wonderful rest of week, everyone, and thank you for joining us. Take care.